with regard to this. I'm talking about the lessons we have learned with regard to drug-eluting technologies in endovascular procedures in PAD so far. So with regard to the drug delivery breakthrough for endovascular intervention, major leaps forward in both percutaneous coronary and endovascular PAT interventions have had unfortunate setbacks, and we all have experienced this, especially in our endovascular space over the last 5 years. 5 years of pain, frustration, and confusions with regard to TCP, paclitaxel-coated TCP. It started with a meta-analysis in 2018, where it was stated that paclitaxel TCP increased mortality. And this was followed by the FDA letter in March 2019, and all the European regulators also followed this advice, and we were not able to use paclitaxel-coated TCP in the way we have become to use it before this meta-analysis has been published. From 2019 to 2023, there was a major effort with regard to reanalysis and analysis of big databases. And finally, this year in July, on July 11th, FDA completely reversed all warnings with regard to paclitaxel-coated TCP. The same issue has happened in interventional cardiology. 3 years of pain, frustration, and confusion with drug-eluting stents. It started in 2006 with a presentation of data at ACC in March 2006. The TES increases mortality after 6 months, and this was also followed by a 3-year journey. It ended only in 2009 at the EAC meeting with a consensus that this was wrong and there is nothing out there with regard to paclitaxel-coated devices, TES in coronary interventions. Just look at the Swedish coronary TES penetration from 2003 to 2007, seeing how broad the usage was before this issue. Then there was the ESC 2006 meeting with this warning, then the FDA warning, and then back to selective use in this was then lower than in 2003 and had an impact on patients. Why? The Swedish use of TES dropped to 5%. So thousands of Swedes had unnecessary second procedures to treat BMS restenosis. And this had an impact on mortality in these patients. It contributed to the worldwide TES panic, and it was also resulted in a worldwide loss of a lot of money, especially for the companies who could not sell their devices and had to re-intervene new technologies. And after the FDA New York and New England Journal of Medical paper, the findings were just plain wrong. So this can happen if wrong data or not good data are published. And at ESC 2009, there was a statement made by James that maybe we did something wrong in 2006, not only because of the devices we were using, but also because of the treatment afterwards we applied to our patient, antiplatelet therapy and whatever. The same scenario has happened for endovascular. As you can see here, we had this meta-analysis in 2018, and then the big amount of patients who have been evaluated, more than 180,000 patients in worldwide who have been evaluated with regard to paclitaxel safety issues. And this is really a huge effort the whole community put into this to come back to a result which resulted in the FDA letter in July 2023, so that we can use paclitaxel-coated devices right now once again. And this is hopefully a reversal of what we have experienced in the last years. Where we are right now with paclitaxel drug-eluting technology and SFA, we are here very at the bottom, just a little bit higher than when we started, but we are not there where we should be. So this is a lesson I think we should have in our minds for the next years and for the future, that we should not publish data which might not be on the solid ground. Paclitaxel was or is for sure the breakthrough drug to address the problem of restenosis in bare technologies for BAD. The mechanism, paclitaxel binds and stabilizes microtubules, preventing their retraction. And this microtubule retraction is essential for cell division, as you can see here. And with regard to DCP application, the excipients are essential for the therapeutic vessel wall uptake. As you can see here in the early trials by Funder, Fembeck, Pacifier, we're all familiar with that. You see here that the late lumen loss, if you use paclitaxel with a working excipient, is much lower than if you use paclitaxel alone without an excipient, as has been shown in the advanced PTX trial. With regard to the Ranger DCP, the coding technology, we have the Transvex technology. The antiproliferative drug is paclitaxel. The excipient is citrate ester. And the presence of the excipient enhances drug transfer efficacy, allows lower drug dose density, and the coating is designed to balance hydrophilic and hydrophobic properties. And this allows adhesion to the balloon during tracking and deployment, allows transfer to the vessel wall during balloon inflation, and minimizes particular loss. So, coating design, the drug and the excipient mix, it should not be too hot, it should not be too cold, it should just be right, like a good meal we want to enjoy. The Ranger paclitaxel-coated balloon catheter, it's a Sterling PTA balloon platform, has the Transpex coating technology, as I already have mentioned, and we all have a very low dose of paclitaxel compared to comparators on the balloon, only 2 micrograms per square millimeter. And the loading tool is designed to protect the drug coating, and the size is available. We have balloons up to 20 centimeters with a diameter of 4 to 7. With regard to the mode of action, the Ranger DCP needs only half of the loaded dose of the impact and delivers low amount of paclitaxel into the circulation. So this is very optimal with regard to any issues of slow flow phenomenon, distal embolization or whatever. Ranger DCP has also similar arterial wall uptake to the impact. So only half of the loaded dose and similar uptake. So with regard to the clinical program, the proof of concept was an RCT where the Ranger SFA showed with regard to the primary endpoint, late lumen loss at 6 months. You see here the favorable influence on late lumen loss at 6 months compared to the control arm. With regard to paclitaxel TES application, for TES polymers are essential for therapeutic vessel wall uptake. You see here a PTA balloon where we don't have a polymer, and when you see here the uptake the influence on the late lumen loss with regard to the vessel wall uptake, with regard to the drug you bring to the vessel wall, you see here that if you don't have a polymer, if you have a polymer-free stent like the V-Flex stent from Cook, there is no significant difference to BOBA alone, and even if you do a dose escalation with no polymer, there is no effect. So with regard to the next generation of SFA drug-eluting stent designs, we need a good bare stent, we need mechanical breakthrough, we need technological breakthrough, and we also need a PTX DS breakthrough. Once again, with regard to the drug release, the percentage of polymers to the drug-loaded density, once again, it should just be right, not too hot, and not too cold, not too much, not too less. So I want to point out the Alluvia coating design. This is an active polymer layer. This controls the release of paclitaxel. It's only 0.167 microgram paclitaxel per square milliliter on the stent surface area. The primer layer promotes the adhesion of active layer to the stent, and the conformal coating, there's a conformal coating for both layers. And even at the 3 times paclitaxel loaded dose, the Eluvia is magnitudes below national safety margin threshold. So you really can achieve a very good, safe result when you use the Eluvia stent with fast tissue absorption, what paclitaxel is providing, and long tissue retention. Sirolimus is the therapeutic delivery of sirolimus from a TCP is difficult because you have tissue absorption which is slow and tissue retention which is short. And therefore, paclitaxel is good for both TCP and TES applications. With regard to the proof of concept for the clinical program, we have the MAJESTIC primary efficacy endpoint, where we see a 9-month primary patency was 94.4%, and I think this is really an outstanding primary efficacy endpoint for a TES. So just let me conclude. Drug-eluting applications for BAD have learned lessons from coronary experience, some pivotal to design, some were unwanted parallels. Paclitaxel delivered efficiently to vessel wall, and this has undoubtedly improved measures of restenosis, late lumen loss, primary patency, and freedom from TLR. With regard to the device design, with regard to the DCB excipient and dose, TS polymer and dose means every device should be assessed on an individual performance, and the Eluvia DS and the Ranger DCP both justified further extensive study in level 1 trials and real-world practice. Thank you very much.
Well, Marianne already introduced my topic here. These are my disclosures. So the next part of the presentations will really make a deep dive into the data we have for the Ranger DCB program. And it actually exists of quite a large program, including head-to-head randomized controlled trials, as well as cohort and registry data. And of course, more data will come out here from the very large Elegance registry, which is well underway. So first, a short view on the Ranger 2 SFA global study. This was really the pivotal IDE trial for the Ranger DCB. It was a worldwide study including 67 centers, and 376 patients were randomized to the Ranger DCB versus standard angioplasty in a 3-to-1 fashion. Importantly, this trial is very much in line with the other pivotal trials, so including moderate complex lesions, I would say so. When we look at the primary endpoint after 12 months, which is primary patency, it's actually an excellent result, almost 90% primary patency at 12 months for the Ranger DCB, and also quite a good result for the standard PTA group of 74%, but of course yielding a significant difference and benefit of the drug-coated balloon. Safety is driven here by events with respect to target lesion revascularization. So we see a low TLR rate after 12 months of about 5.5% in the Ranger DCB group, and this was 3 times higher in the standard angioplasty group through 12 months. But of course, we want to have a longer look at 3-year primary patency rates here in some of the pivotal DCB trials. The Ranger balloon so far performed best with a 3-year primary patency rate of 77%. And also important here, there were still good results for the uncoated balloons. But I've said before, here the DCB really is the best result so far. And this also is corroborated by the 4-year freedom from TLR rates, which are around 78.7%. So a bit more than 20% of patients had to undergo re-intervention over this long time period of 4 years. Now I'm moving forward to the first head-to-head comparisons of different drug-coated balloons, which is the COMPARE RCT. Here, 414 patients were included. It, of course, had a different design. It's a non-inferiority trial. And again, primary patency at 12 months was the primary endpoint. But follow-up will continue until 5 years for safety. What did the COMPARE trial compare? Well, the high-dose impact DCB with the free-pack coating technology versus the Ranger Boston DCB with the low-dose 2 micrograms per square millimeter coating technology. And Marianne already highlighted the specific aspects of this coating technology. The patients were randomized in a one-to-one fashion, and the primary endpoint for non-inferiority was met, of course, in this trial, with a primary patency rate of 83% in the Ranger group versus 81.5% in the impact group. Again, we see a very low safety event rate. Freedom from major adverse event was over 90% in both groups, and also here the primary endpoint for non-inferiority was met. What I really found fascinating were these overlapping Kaplan-Meier curves through 2 years. We have a primary patency rate after 2 years of 70% or a bit over 70% in both groups. And of course, here's no statistical difference. COMPARE was a bit unique with its trial design because it actually also included long lesions up to 30 centimeters. And there was a lesion length stratification in the beginning, to have short lesions up to 10, middle length lesions 10 to 20, and the long lesions 20 to 30 centimeters. As you can appreciate, we did not see any signal for a different efficacy between these groups. But what we saw is really that bailout standing actually rose per tertile. So in the short lesions, it was around 13%, and in the long lesions, 20 to 30 centimeters, almost every second intervention actually needed bailout stenting. This is also what we know from registry data of long lesions, but it's still quite impressive. So, of course, the question comes up, what can we do with adjunctive preparation in challenging lesions? Is stent avoidance a goal, a vision in itself? And new technologies that actually aim to alter the compliance of the vessel wall before subsequent treatment, like the intravascular lithotripsy, would that have a durable impact on patency? And of course, the big question, what about plaque removal? Could via atherectomy, could that actually have a patency benefit? Well, as you all know, we can't really conclusively answer these questions, but we do have some indications. So an interesting study with respect to these questions is the DISRUPT-PAD3 trial, of course, comparing IVL plus DCB versus standard angioplasty plus DCB treatment. Importantly, and this is also unique to this design, bailout stenting or stent implantation was considered a patency failure. And this is the reason why you have this decline in the standard group without IVL in the very beginning, because it actually needed more bailout stenting. After that, when you do a landmarked analysis of the two groups, not including bailout stenting as a failure, you actually see no difference of these two treatment strategies over 2 years with respect to primary patency. And of course, freedom from clinically driven TLR, there is no difference, as here bailout stenting is not an issue, is not considered a failure. Just as a side note, actually those patients who received the stent had the best patency result over 2 years, it's 94%, but of course this is just hypothesis generating. The Jetstream atherectomy plus DCB registry really included patients with long lesions. So DISRUPT-PAD was rather short, around 10 centimeter median lesion length. Here it's more than double length, it's 24 plus minus 5 centimeters. When we first look at procedural success, well, we can appreciate that actually technical success, defined as a residual stenosis below 50% after Jetstream use, was pretty frequently achieved in 88%, and after additional DCB angioplasty, procedural success with a residual stenosis below 30%, was also 99%, and only 7% of patients needed bailout stenting. When we look at the TLR rate after 1 year, it's pretty good. Let's say it's very good. It's 93%. So now we are really focused, I think, on clinical trials that were performed predominantly in the US and Europe, but we also, this year at the GET meeting in Tokyo in May, the Japanese colleagues brought out new registry data, which is pretty interesting and I think really stimulating. So the popcorn registry included around 2,500 patients, of course, already almost 3,000 limbs. And what's highlighted here, as always in the Japanese data, they really included complex patients and complex lesions. So diabetics, 2/3 of patients were diabetics. That's actually what we normally see in the BTK trials and not in the FEMPOP trials. And 41 patients were on dialysis. This also corresponds to a high CLTI rate of 1/3 of patients, and the inclusion of pretty long lesions with a mean lesion length of around 13 centimeters. What's also very specific for Japan, a very high use of IVUS in 3/4 of cases. And here they actually included 75% of patients who were treated with an impact balloon and 25% with a Lutonix balloon. These are the freedom from TLR rates as well as primary patency rates over this follow-up period of 30 months. And after 2 years, primary patency in these complex patients and lesions was around 70%. They then performed interesting sub-analysis, for example, comparing intraluminal versus subintimal recanalization. And they actually saw a signal that intraluminal recanalization would perform better with respect to freedom from restenosis, which is a bit in contrast from our data which came out from Europe and also worldwide in other registries. When they looked at the specific balloons here, the impact definitely outperformed Lutonix with respect to freedom from restenosis. And this is also shown here at the 12-month data, where you can see clearly an improved patency rate of around 88% with the impact balloon, as similarly to an improved rate at 2 years with respect to primary patency. The colleagues then also included a type R population, and this is patients who were then treated with the Ranger DCB in this registry. And this is a short overview how here the results would come out. Importantly, in the original popcorn registry, lesion length was around 13 centimeters on average. In the popcorn type R registry, so also including Ranger, it was about 40% longer in the Ranger group. A little bit more CTOs and also more severe calcification. Despite these more complex lesions here, also the Ranger balloon performed very well at 1 year with a primary patency rate of 82%. So there's another registry that was presented this year, GET, out of Japan. It's a propensity score matched analysis now, because what we have seen before was really unadjusted data. And here 580 patients were included, and after propensity score matching, you really can appreciate comparable lesion and patient characteristics between the low dose Ranger and the high dose impact group. When we look at the 12-month primary patency rate, it was about 87% in Ranger versus 81% in the impact group. And of course, that was not statistically significant. It's interesting because actually these values are very similar to the COMPARE trial of what we have found there, because we had around 87% primary patency rate in the COMPARE trial with the Ranger DCB, and that was similar to what the Japanese colleagues found in the PROSPECT Monster registry after propensity score adjusting. The lesions were kind of more complex in the Japanese cohort, with a longer lesion length, more CTO, and more calcification in here. So it's really interesting that actually the DCB performance was comparable between Europe and Japan. But to highlight again that in this registry data out of Japan, the age percentage of patients with diabetes as well as chronic kidney disease and hemodialysis was much higher. longer lesions were included, more calcification. And again, here, what's typical for Japanese data, frequent IVUS use. And I think what's most striking actually is the low bailout stenting rate, as really it's actually against the IFU to use stenting after DCB in Japan. So they really try as much as they can to avoid bailout stenting. And despite this low rate, there was this excellent patency rate. So in conclusions, the Ranger DCB clinical program has 2 RCTs so far against various standards of care. The PTA, again, the pivotal IDE trial against standard angioplasty and the COMPARE trial against IMPACT DCB. The primary endpoints were met in Ranger SFA2 as well as in COMPARE, and it's actually the highest 3-year primary patency rate so far reported in any IDE trial. Japanese data demonstrates inferior primary patency for the Lutonix DCB versus IMPACT DCB in this unadjusted analysis. When you also include Ranger DCB for this analysis, you actually see a comparable efficacy compared to IMPACT DCB despite more complex lesions. And the propensity match prospect monster demonstrates similar outcomes as COMPARE, but as there's no difference between low-dose Ranger and high-dose IMPACT. But of course, it's really important that the primary patency is high in both trials, despite the lesion patient and procedural characteristics are very different. Thank you very much.
Thank you, Marianne. And definitely, drug-eluting devices should be the first line of treatment of the femoral segment. And as Sabine said, we have definitely huge data now with DCB, but also we have very important data with DES. And so if you look about evidence for SFA, we have now with Eluvia and Ranger more than 10,000 patients assessed in more than 15 countries. And if you look DES, we have RCT and we have registry to assess the value of these devices. Eluvia, so a polymer eluting stent, has been assessed by 2 RCTs, and one is coming. Sports will be released at CCT in a few weeks. Very briefly, Sports is a 3 arms RCT, 1 arm with a DCB, the second arm with bare metal stent, and the last arm with Eluvia. And so the results will be released soon. Imperial and Eminent have been published. Both are head-to-head comparison. Imperial compare Eluvia versus Zilver PTX, a non-polymer drug-eluting stent. It's a 2-to-1 randomization. Mainly, claudicant patient has been assessed with lesion inferior to 14 centimeters, and the first endpoint of this study was the primary patency at 1 year. Eminent is also RCT, 2-to-1 randomization. It's a larger study about Eluvia with more than 775 patients. Also, claudicant patient has been included, and the lesions are quite longer, up to 21 centimeters, and the primary patency rate is the first endpoint of this study. If you look both studies have reached their primary endpoint. Imperial, showing the advantage of Eluvia versus Zilver PTX in terms of primary patency at 1 year, 86.8% versus 77.5% at 1 year of primary patency. And Eminent, the superiority of Eluvia versus bare metal stent, with 83.2% of primary patency at 1 year versus 74.3% at 1 year in the BMS group. But also we have some prospective registry to assess Eluvia outcomes. We have this registry, and perhaps the main registry here are the Münster and the Desfinado registry. Why? Because in fact in Münster they assess different kind of lesions. They assess long lesion, and you can see that the mean lesion length is about 20 centimeters. And why Desfinado is also interesting, because in this study they assess different kind of patients. They assess CLI patients. And what we observe here despite the different severity of lesion, despite the different morbidity of the patient, we have still amazing results in terms of primary patency. And you can compare these results to RCT, to Eminent and Imperial, and to Majestic, and to Outclone all-comer registry. We have also some post-market registry, REGAL, and the criteria are pretty similar to Eminent. You can see that the lesion length is similar. But in this post-market real-world setting, in fact, registry, you achieve also a pretty high patency rate, 92% versus 85% in the Eminent RCT in Europe also. Capsicum is very interesting for different reasons. First, because it's a large registry, large prospective registry, more than 1,000 patients, but also because it's a real-world setting registry with long lesions. The mean length of the lesion is about 18 centimeters. But look at the severity of the patient. 61% of diabetic patients, 28% of hemodialysis patients, and at last, 35% of CLI patients. And so despite of the severe lesion, severe comorbidity, in this study, you have at 1 year, 88% of primary patency, and after 2 years of follow-up, 85% of the patients are free from reintervention. And so if you look at the results of Eluvia in registry, in different design, in RCT, is quite pretty consistent, and the primary patency is close to 90%. It's also true for the TLR. If you look at the TLR, according to the design of the study, you have still the same kind of results, and after 2 years, 9 out of 10% patients are free from reintervention. Also, if you compare the patency and the TLR with other kind of devices, such as self-expandable stent or cover stent, you have still this delta performance, 10% in comparison to self-expandable stent, including also cover stents. It's also true for the TLR, with still this delta performance of 10% versus self-expandable stent and including cover stent. So coming back to Katsanos, in fact, Katsanos start to study the cost effectiveness of devices. And in this release of 2016, published in BMJ Journal, he concluded that the widespread adoption of drug-eluting endovascular therapy for femoral popliteal disease would add meaningful clinical benefit at reasonable additional cost to the NIH system. So we update a little bit this data by including the last Eluvia outcomes. And what we observe here, we observe the cost effectiveness. And so to assess the cost effectiveness, we use the ICER, the incremental cost ratio, which is in fact a ratio between the cost and the quality. So quality is the quality of life in good life at 1 year. And what we see here, we see that for bare metal stent, we have a quality benefit, but with a higher cost. And when you see all these drug-eluting devices, we have also a lower cost, but we increase the quality benefit mainly for DS, for Eluvia in this case. And we can explain this difference because of the lower TLR for Eluvia. You can see here that at 2 years, the Eluvia TLR is lower at close to 9%. And the number of patients to treat is also, to avoid 1 TLR, it's also lower in Eluvia with 5.6 patients to treat to avoid 1 TLR. Coming back to Japan, in fact, in Japan, they perform analysis comparing using propensity matching analysis, DCB, using here impact, DCB, and also using the Capsicum study, Eluvia DS. And in this study, they look at the restenosis at 1 year, and they observe, according to this 2 prospective large registry, that Eluvia did better than DCB in terms of restenosis at 1 year. in an unmatched group, but also in matched group. And you can see the difference, the significant difference. In an unmatched group, it's 16% of restenosis versus 21% in the impact DCB arm. And in the matched group, it's 15% of instant restenosis at 1 year versus 23% in the DCB groups. Also, you have analysis according to the lesion characteristic. Iluvia didn't provide any significant advantage for stent-in-stent patient, but also in case of no runoff. But Iluvia DES is dominant regardless of reference vessel diameter, lesion length, chronic total occlusion, calcium, and popliteal involvement. So to conclude, Iluvia clinical program has now many data with 3 RCT and many registry, and all these data are consistent regardless the lesion, regardless the patient severity. And we still have a performance delta around 10% for primary patency at 1 year, but also for freedom from target lesion revascularization at 2 years, favoring Iluvia, and it seems reproducible in multiple settings against any stent class. Both ICER and number 2 patient to treat suggest that Iluvia is also economically beneficial. And at last, propensity score and adjusted data from Japan of Iluvia versus DCB support a hypothesis of superiority of primary DS versus DCB. Thank you for your attention.
Not only vessel lessons forgotten question mark, why vessel prep, but also assessment after vessel prep and optimization of our definitive therapy are still key factors to reach a perfect result. These are my disclosures. So, in my opinion, the golden rules for any endovascular treatment: first of all, you definitely need to prepare the vessel. Afterwards, you need to assess your way of preparing and the final results of preparing. Then you need to decide what you're going to do. You continue with angioplasty, or you need to add scaffolding or whatever. You need to deploy your definitive treatment in a perfect way and try to optimize this in order to get a perfect outcome. So I'm jumping in this circle, I'm jumping in the deciding process here. When we are deciding to use a DCB, for instance, result with angioplasty alone in your vessel prep was perfect, so it is an angioplasty responder and you continue with drug-coated balloon technology. Well, here you need to take care of some rules, let's say. First of all, what we learned from the first generation of DCBs, more particular out of the Levant 2 data, is that balloon transit time can be important, a little bit device specific. If you have a perfect coating and excipient, then probably this is not that important, as the paclitaxel is sticking quite good on your balloon, but with some devices it is important. For all drug-coated balloons, inflation pressure and wall positioning of your drug-coated balloon, extremely important. The balloon inflation time, we all know the importance of prolonged inflation time. And then also the result of your DCB maneuver, so the final residual stenosis after your definitive treatment. And here you've seen that taking care about all these variables, well, that the primary patency result at 1 year was improved if you are taking care about 3 variables. But if you can taking account with the 4 variables, the pressure or wall positioning, the inflation time, a residual stenosis at the end of less than 30%, and a perfect balloon arterial ratio, almost 1-to-1, then you can have a perfect optimized result in terms of primary patency and freedom from TLR. If we are looking in the drug-coated balloon trials at some predictors for failure, loss of primary patency, binary restenosis, TLR, you see that a lot of these predictors are not so lesion or patient specific, but are operator dependent. The most important factor, the predictor factor, is residual stenosis at the end of your procedure of more than 30%. So in my opinion, a residual stenosis of 30% at the end of your procedure is a failure boundary, and cannot be a target. How to deal with these type of complications post-DCB? Well, you see, for instance, in the IMPACT trials that in the patients where we had residual stenosis of more than 50% at the end, well, 56% was treated with a scaffold solution. When we had flow-limiting dissections, 60% was treated with a scaffold solution. And then there is some discussion, some debate on how to stent. Do we need to create a full metal jacket? Do we need to do a kind of spot stenting? Or do we need to do something in between? So mixed stenting strategies. Anyway, it is clear out of a lot of drug-coated balloons that in general, here you see some data out of the IMPACT trials, but also the COMPARE trial. You see that if you are talking about lesions less than 10 centimeter, we notice that the odds ratio for stenting is 1 out of 10. When we are talking about between 10 and 20 centimeter, you see that still 1 out of 5 needs to be stented. And when we are talking about longer lesions, my daily practice lesions, by the way, more than 20 centimeter, we notice that it is almost 50-50. So 1 out of 2 is receiving at the end of the procedure a stent. So commandments in terms of DCB, optimal pre-dilation preparation is mandatory. Use a sufficient diameter of your drug-coated balloon, a 1-to-1 to the vessel diameter. Inflation time, at least 2 minutes. I prefer 3 minutes or even more. And don't leave a residual stenosis of 30%. If you cannot improve this by angioplasty alone, use a scaffold. If we are deciding to use a drug-eluting stent, well, how can we optimize this? Here you see some of the predicting factors out of the Capsicum trial concerning the use of an Eluvia drug-eluting stent. And you see that majority of these risk factors, let's say, are patient or lesion dependent, except for one, spot stenting. So spot stenting, short stenting, and not covering the full lesion was really a factor for restenosis. So how can we explain this? I don't know. Is it a problem of edge of the stents? Is it a problem of geographical misses? Hard to say, but anyway, spot stenting is a risk factor. Lesion length, for instance, if you are using an Eluvia drug-eluting stent, was not a risk factor for restenosis in the Capsicum trial. Also important, I think, when you are deploying a stent is to create a perfect wall lap positioning and a perfect deployment, a full deployment of your stent. This is nicely, let's say, figured in the minimal stent area. And you see that if we are reaching on IVUS analysis, also a new insight from the Capsicum trial for peripheral, it existed already for a long time in the coronaries, but if you can get an optimal MSA, you can see that you are reducing stenosis on the longer run. Here another case, another study that was done with the Supera, for instance. Also there it was quite clear that a poor stent expansion is really affecting patency, so you definitely need to strive to a mean stent area, a minimal stent area of more than 15 square millimeter if we are talking about a diameter of 5 millimeter. So I've always learned the rules with the Abbott Symposium and whatever, and how do you need to implant the ideal Supera, and there you see all the commandments, but actually this is not only valuable for Supera, but in my opinion, valuable for all the stents, all the scaffolds that we are using. And indeed, these were also important lessons that were learned from Stephen Cum out of the Desafinado trial, the CLTI trial with Eluvia. Also there, he stressed very importantly the lesion assessment in two-view angiography, a perfect vessel prep, pre-dilatation, 1-to-1, then to decide DES or DCB, aggressive pre-dilatation with non-compliant balloons, drug-eluting stent with Eluvia, and a post-dilation to get a perfect wall lap positioning and a maximal stent area with high-pressure balloons. And these are the commandments for the use of drug-eluting stent. A final topic, Can more accurate vessel interrogation help? I've shown you some pictures, some studies where there was an IVUS analysis done in order to improve final results. Well, anyway, it is quite clear that just eyeballing by a radiologist or a vascular surgeon is definitely not sufficient. If you see the difference between the by site or operator estimation and the core lab analysis in the real PTX study, for instance, this is a huge difference. So the operators are consistently overestimating their fantastic procedural success. The same in the Disrupt PAD3 trial. Also there, you notice a very important difference between site reports and angiographical core lab reports. So important to notice this. Of course, the experts of IVUS use, also in peripheral, are our Japanese friends. And in an analysis, a retrospective analysis of almost 50,000 people, you see that the incidence of repeat intervention was significantly lower in the IVUS group versus angiography alone group. So it is associated, the use of IVUS, with a reduction risk of repeat intervention of 75%. There is also a randomized trial out of Australia, where two groups with IVUS and without IVUS were compared, and also there we noticed a difference, a statistical significant difference in terms of binary restenosis at 1 year in favor of the IVUS use in peripheral procedures. And also USA is confirming these results in a huge analysis of IVUS or non-IVUS. Here you can notice the data of our US friends, 30% reduction in major adverse limb events, including amputations during lower extremity arterial interventions guided by IVUS. Of course, I'm working in Belgium, a poor country, and IVUS is not reimbursed and not available over there. So how can we solve this issue then? Well, if you are doing a two-projection detailed angiography, you can also get some nice insights in dissections, yes or no. And this is a nice study of Kobayashi, saying that if you have like group C here in this study, dissection, so width of the dissection more than 1/3 of the lumen, that you see a very important decrease or drop in primary patency at 2 and 3 years compared to the groups where the dissections are not so pronounced. So, in my opinion, the take-home messages, ladies and gentlemen, optimal vessel prep remains key to drug deployment, no matter which drug-eluting therapy is used. It allows DCB to go to the reference vessel diameter ratio, and it allows your drug-eluting stent to achieve an optimal minimal stent area. Operator controllable factors are significant to outcomes. Predilatation, leaving residual stenosis, leaving high-grade dissections, lesion coverage, geographical misses, and stent undersizing are well-known factors and predictors for restenosis, and probably IVUS may improve in the future the analysis and the clinical outcomes of our peripheral procedures. I thank you for your attention.
So we have some 10 minutes left for discussion. I didn't see any questions in Slido. Are there any questions from the audience? Okay, then I want to start. So we were discussing about the drug. I guess sitting here, we all think the paclitaxel is good, has its efficacy, and is safe. Do you agree? Koen?
After seeing all these data of Sabine and Jan and you saying that paclitaxel is good is the understatement of this symposium. It is perfect.
Perfect.
Correct or not?
Yeah, correct.
I cannot see how some other drugs or whatever can improve these kind of efficacy results.
I completely agree, and I think it's very, very important that this first big meeting after the FDA statement really comes to the conclusion that we have a perfect drug for SFA treatment right now. The only question I have is, what should we use? Bare metals, DCP or TES? Or can you give me some hints, Sabine and Jan? You know, I'm in the cath lab, I see a lesion. How should I decide? Do we have an algorithm, Jan?
I think we should use both.
Yeah, but when?
It is a question. So far, it is a question. Perhaps in the coming sports study, we will have some response because we have 3 arms with DES and DCB, so we will have some insight. But in fact, in current practice, we need both. What I did, in fact, in my routine practice, my main limitation to use DES is the length and the diameter. And when I have intermediate lesion, what I use DS because I think it's more simple. I have not to check if I have dissection or what. And I don't care of leaving nothing behind. You know, leaving nothing behind is not outcomes, huh? It's a marketing sentence. And so my purpose is to look the patency, is to look the TLR. And using DS for intermediate lesion, I have good results. In case of long lesion, so long lesion is not 15, it's 30 centimeter, 40 centimeter, 40 up to the popliteal level. I need long lesion. And so far, I didn't have this ability to use 3, 4, 5 stents, you know, to treat all these lesions. So in this case, I use DCB in my routine practice.
And if you have a dissection, do you place a TS or a bare metal stent?
Bare metal stent.
Maybe, well, I still do care about leave nothing behind, especially in young patients, I have to say so. So it really depends on the scenario. What we actually see is that typically the whole SFA is diseased in these patients, even if we don't have only to treat a certain part of this. And we know that most of our patients will come back. And so for me, it's a little bit a question, how often do I expect the patient to come back? If it's a young patient, I really still try to go for leave nothing behind, and DCB would be the primary goal to go for. But of course, in CLTI patients and so on, the threshold to use a stent is much lower. Yeah.
And with regard to vessel prep, and especially the decision, I mean, there is a lot of discussion about using IRIS, and that can help us and improve the outcome. But we know in daily practice, in 80% in our daily routine, this is an add-on tool. It's not only expensive, it's an add-on tool. It takes time to bring the iris in, to do the iris measurement. So what do you think, the three of you, how can we improve it without an additional tool? You already have mentioned different angulations. So how do you decide?
Yeah, for me, this is right at the moment, for the reasons you mentioned, hard to use, to applicate in daily use, not reimbursed, adding time, costs to your procedure. I want to keep our package of money we have for the definitive treatment. So I perform a 2-projection magnified angiography. And based on this, and I also want to have this flow dynamical information. Yeah, but it remains subjective. I totally agree. And if there would be in the future a very straightforward, easy way, intraluminal way of imaging, cheap, then I think that's the way to go, and to size and to decide about dissections or not, residual stenosis, and so on. That's what we need.
I mean, for me, it's similar. Of course, IVUS is really reserved for selected cases. It can't be used on a daily basis. I always tell myself there's a publication in cardiology, actually experienced interventionist, the benefit of IVUS is less, so this is what I'm telling me. And then there's also the statement, actually what we have in our lab, pain is the poor man's IVUS. So it's really, pain is a very good indicator in almost all patients if you're almost right with the sizing or not. If the patient doesn't feel anything, so it's always, I think, most of the time you probably are undersized. So that is helpful too, I think so. And then, of course, different projections, the flow. I mean, for me, the most important still is the SFA must be faster than the profunda. So like the standard things, I think so.
You know, as Belgium, in France, we are also a poor country. So IVUS and atherectomy are not used in daily practice. My belief about this, we have more and more evidence about the IVUS use. And definitely is very useful, in particular for this long, complex lesion to assess the spot stenting, etc. Regarding atherectomy, it missed data. Atherectomy or lithotripsy, we are missing data, definitely, to use it, in fact, in regular practice. We have the need to improve the vessel preparation, but so far, we have no the data to use it in daily practice.
The last word to Koen.
I just want to ask a question to you, Marianne. So you were rather negative on the paclitaxel gate, and 100% correct, stating that physicians, authors, reviewers, journals, everybody involved in this publication process needs to be very careful in terms of what is published. We've seen. I agree with this. I also want to give it a positive note. So are there lessons that we've learned, positive lessons, how to do better, and so on, out of this paclitaxel gate?
You always find something positive in something negative, and you always learn something positive out of a negative thing. I think what we have learned is that we have to set up trials in a better way, that we need to analyze data in a better way, that we need to look to larger databases, that we should also look to real world data, and I think. And I think that's a lesson we have learned. Not only setting up a small trial of whatever, just see what is the outcome. We have to look for long-term data, not short-term data only. And what was the positive effect? I think it really joined forces worldwide. So people working in this field, they are right now working together. And I think that's for the purpose of our patients.